Are you looking to scale up your healthcare solution in partnership with leading healthcare companies such as Anthem, Chicago Pacific Founders, Evernorth, and United Health Group, with over 200 million members? Applications are open for the 2021 UCSF Rosamond Adapt program. Startups developing breakthrough technologies that improve healthcare efficiency will receive $100,000 cash support and connections to payers. To apply, please visit rosamondinstitute.org. And now, from San Francisco and the UCSF Rosamond Institute, the Health Technology Podcast with your host, Christine Winoto.
Our guest today is Chris McFadden, Managing Director at KKR, a leading global investment firm working with healthcare companies. Chris is also a founding member of the COVID Patient Recovery Alliance, a contributing author to MedCity, and a board member of several medical and healthcare companies. In this episode, Chris and I begin by discussing what it means to work at a global investment firm, which lead to some big questions about medicine in a post-pandemic world. What are the benefits and drawbacks of telemedicine? How will increased awareness of mental illness affect medical system? And how can healthcare companies continue to adapt as the world reopens? Here's our conversation. Welcome, Chris. Thank you for joining me this morning.
Really pleased to be with you. Thanks for having me.
Yeah, so I found you've been in the industry for many decades, and I thought it would be good for our listeners to hear about your background and the career path that you took that brought you to where you are now, and why healthcare as well.
Sure. Pleased to share at least a summary. So I studied political science and finance as an undergraduate. Healthcare was not necessarily part of my plan or vision, but had an early job working in the securities industry for a research analyst who focused exclusively on healthcare and healthcare delivery, health information technology, and other sort of infrastructure elements. And what I found about that is it was this really organic intersection of things that I knew and had studied, right? Understanding policy and policy making, understanding the allocation of scarce resources, understanding how you finance things, particularly in areas like research and development, and the role that the capital markets can play in supporting those endeavors. And so it really appealed to me on a couple of aspects. And I think, moreover, it's such an interesting and complex market. And, the opportunity to continue to learn and be more knowledgeable, I think likewise appealed to me. I think healthcare is one of those markets you can spend your whole career and still feel like you're learning about new aspects of the outcomes research or payment reforms, for example. And so for about a dozen years, I wrote what we call sell-side equity research. So I worked for an investment bank, including Goldman Sachs. We wrote industry and company research reports about publicly traded companies like McFadden here in San Francisco, and HCA, the hospital company, and Cerner, the large health information technology company. But one of the things that I realized is that the more innovative companies often never found it their way to the public market, that they were either acquired by a large company or otherwise went through a different life cycle. And so made the decision to leave the research and publishing part of my responsibilities and move into the principal investing area, what we called our special situations group at Goldman, later a private equity firm based here in San Francisco, and now with KKR, which is a large multi-asset class investment firm, but really always employing the same toolkit, which is understand, what's happening in the market, whether that be the needs of patients, reimbursement policy changes, et cetera. Understand which companies are doing it really well and can demonstrate a strong health economic outcome, and then financing or investing in those companies to help them achieve their objectives. And have continued to do that work in small companies, medium-sized companies, and large companies, and continue to think it's an area with a lot of dynamism, which is generally good for people who are putting capital to work.
Mm-hmm. So maybe you can share us a little bit about KKR. It's like really big company, but if you're not in the sector, probably people are like, what is it?
Yeah. So KKR was started as a partnership roughly 45 years ago. Henry Kravis and George Roberts, which are two of the founders, continue to run the firm as co-CEO today. What started as a company that was focused on one product, which was, leverage buyouts or large private equity transactions, has now developed into a firm that has many investment strategies: buyout, growth, energy, infrastructure, credit. And we think as a firm, having more ways to partner with management teams and companies just allows us to be better at our jobs. The firm spends a lot of energy focusing on culture, really maintaining the integrity and the continuity of what the original founders wanted to create in KKR, survives on, even though we have grown both in numbers and in assets under management. Today, we're just under $300 billion of assets under management, but we're less than 2,000 employees in the global organization. And so, even though we have some benefits of scale and some benefits of the size of the organization, it's really important that we maintain that partnership culture, that we work hard to be collaborative with our colleagues across region, across industry, across asset class, and hopefully do best by our clients, because we never lose track of the fact that at the end of the day, our real clients are firemen and policemen and healthcare workers and other employees who have contributed to some pension product and are expecting that pension to generate adequate return to support retirement. That's really our mission, and obviously an important one, and one that we want to give our 100% of our effort toward.
So can you give us an example of a case study of how KKR worked with a healthcare company? Because I know you have the biopharma, they have the healthcare services, you also have the medical devices. How is that KKR role and what that means to a company who are interested in working with KKR?
So thanks for the question. From my perspective, we approach almost all investments in a very similar fashion, right? Firstly, KKR is always going to be a friendly suitor. We're never going to approach a company in a hostile or unwanted way. Secondly, we're looking for businesses that are at some inflection point where new capital, new network, new expertise could significantly improve performance. And then finally, we're looking for alignment on, what are the ways that a company or management team could, benefit from whatever resources KKR may be able to bring. That might mean new capital to enter new markets. That may mean technical expertise, either in-house with our Capstone Group, which is an in-house consulting organization, or through outside experts that we have existing relationships with. That may mean our network within an industry or regulatory or other audience. And, often, combining those things with an already high-performing team is a nice formula, good for the business and its employees, good for value creation for the organization, and again, really important to us, really good alignment between KKR and our investors and the leadership team and existing shareholders that we'll be partnering with.
And how do you say your model different from, say, a venture capital's?
Yeah, that's really a staging question. Venture capital firms, and here in the Bay Area, we are blessed, obviously, in and around Palo Alto with probably the richest concentration of venture capital firms in the world. Those investment professionals are looking at early stage companies, sometimes pre-revenue, right? Often pre-revenue, certainly in the context of biotech and life sciences, but often too in the context of technology businesses that have a particularly disruptive, really incrementally innovative idea, or taking advantage of some market dislocation in a way that produces Uber or produces some of the other, well-known now mass adoption consumer or technology solutions. KKR is not a venture stage investor. We really look at businesses that have already established themselves commercially, already have a product that's been approved and is in market. It may be a $50 million company, it may be a $5 billion company, but we aren't taking the risk that the business or technology isn't going to work. Instead, we're asking ourselves, can the commercial adoption be accelerated? Can we enter new markets? Are there things in cost structure that we might be able to improve? Other, ways to help a company reach that next threshold of commercial success.
Okay, well, that's good. Thanks for the overview. I thought maybe since you've been following the industry for many years, and can you give us an overview of how the industry, the healthcare industry, technology has evolved for the last decade, and now how you think it will transform in the next 5 years?
Yeah. So I think it's really interesting because, when we're talking about healthcare technology for the moment, let's focus our conversation around those that touch the provider-patient interaction. There's lots of healthcare technology, but I think the most interesting is what's happening at the intersection of provider care and patient experience. And as people will remember, prior to 2008, it was, a long story about how paper-intensive, how uncontemporary, how underinvested the U.S. healthcare delivery system was in the sort of, technology tools that other industries had developed, decades earlier, right? And so we get meaningful use, which was a federal subsidy for providers to invest in electronic medical records, essentially take us out of a paper-based filing system into a digital-based filing system. Big institutions, mid-sized institutions, small practices overwhelmingly use that subsidy to digitize the underlying medical records that they use, as well as to do things like e-prescribing and other workflow tools that helped increase efficiency and compliance. In many ways, we're just coming out of that first step. Now, the second step is, well, if you really have digitized the vast majority of information and transactions in healthcare, what does digital transformation look like? How do we reimagine the patient experience? How do we reimagine how clinical productivity can be increased? Because we're now using these tools in a more sophisticated way than just digitizing an existing paper process, which is really what the first stage of this is. And so when you look at all the enthusiasm around digital health, that's really what I think that means. Digital health is now bringing all sorts of tools to bear, sitting over an existing now digital infrastructure and asking ourselves the question, how could it be different? How might we monitor, for example, diabetic patients' A1C level that doesn't include pinpricks and instead can be done with a long-standing device that communicates through the phone, maybe back to a physician practice, right? So Dexcom now is really well understood, really widely adopted, a good example maybe of that sort of experience. And I think you could find use cases throughout both the incubators as well as increasingly commercial stage organizations. I would just add a third layer to that, which is maybe a separate topic, which, okay, well, now how does telehealth shape that experience as well, which begins to really think differently about the physicality of the physician and patient interaction, not just about how we do some of the workflow that surrounds that traditional experience.
This podcast is sponsored by Brown Rudnick's Global Life Sciences Group, a team of legal professionals that help life science companies, lenders, and investors around the world turn good science into good business. Learn more at brownrudnick.com. This podcast is also sponsored by Canon Quality Group. Canon Quality Group has been helping medtech startups set up quality management systems for over 10 years. If you're unsure when to get started with quality management in your startup, turn to the experts at canonqualitygroup.com.
And so with the pandemic, we see that the acceleration of people adopting a lot of the virtual care. And some people can't wait to go back. Some people don't want to go back. And also, how do you think that, pandemic will impact how we deliver care in the next 5 to 10 years, and especially with a lot of the digitization technology that happened already in the past decade?
Yeah, and that's a really good point, right? Because the point you just made is the necessary stepping stone to something different. Listen, I think if we were having this conversation in January of 2020 and we were talking about telehealth generally, we might highlight things like telestroke, where there was clear adoption, particularly outside of academic medical center. But otherwise, I think we would be talking about a technology with a lot of promise, but not necessarily close to what I'd call gold standard mainstream clinical care. What the pandemic accomplished was to force all stakeholders, patients, providers, regulators, health plans, government policymakers, to experience telehealth in some form or fashion, either directly or through a loved one. And I think for the most part, come away recognizing this is a really effective modality. There's a lot of value to be able to change, as I mentioned earlier, the physicality of my patient-physician experience without losing or decaying the quality of the care. And at the same time, benefiting patient outcomes, because, more likelihood that you're going to get continuity of care, more likelihood you're going to get regular and consistent follow-ups, more ability to be responsive to people who are mobility challenged in one way or the other. And so to me, that now opens up the aperture to say, okay, we have the underlying digital infrastructure. We now have a willingness and a capacity to think differently about care delivery. Where does that take us? And I think that's where we are. And I think there's lots of paths that it might imagine. Certainly leading institutions like UCSF seemingly are using it in pretty progressive ways to offer patients choices. In the first instance, I imagine over time, however, it's also going to redefine the competitive landscape, because the fact of the matter is that if I want to see a patient who's not in the Bay Area, that was a hard catchment area conversation for a provider like UCSF. Today, if I wanted to have a patient in Nevada or Reno or Missouri or Florida, depending upon the disease state, that could very practically be a UCSF patient. And so that phase of the dislocation is probably still in front of us, but I think is going to be something we're going to have to think through. And there's a lot of investment capital that's following to help explore some of those ideas in more detail.
And so I think, which is great, right, to have the access to high quality care. Mm-hmm. And I think the telehealth the pandemic opened up our eyes, that we can see our doctor. But I think at some point there's a portion that right now we still cannot do it just through the video call, I guess. And what do you see that trend, how can we make the telehealth become a smarter or more realistic way of providing care without driving to San Francisco if you were up in Nevada?
Yeah, so I think that's a totally appropriate question, right? There's two elements of it. There are certainly some clinical areas like behavioral health where, a virtual experience between provider and patient might actually be a very durable relationship. And in fact, in some cohorts, in some populations, preferred than in person and more clinically effective. Now, it doesn't mean that patient may be seeing their provider only from home. They may go into a clinic in their local community where there is an infrastructure around them, but their provider may still be, in San Francisco or Seattle or Salt Lake City. So that's one aspect of it. I think the second aspect of it is, I think we want to focus on those conditions like chronic conditions where really the clinical value, the outcomes and health economic benefit is the continuity of patient management over time, right? Which is a combination often of in-person testing and other outpatient experiences or outpatient care, much of which can be architected on a remote basis. And so I think it's not productive to think about as all or nothing. I think it's productive to force rank the places where it's probably best suited, to think more expansively about network and local provider support for the infrastructure, testing and otherwise. But there's still going to be, I think, value that accrues to those leading institutions that have the academic reputation, have the specialty programs, have the specialist care that people are going to seek out, and local providers are going to have to consider that in their commercial planning processes.
And so the other thing, thank you for that answer. The pandemic also highlight a lot of the issue with the mental health, and there's a lot of shortage of mental health provider, and I think that telehealth is something that hopefully change that. I know that you're on the board of telepsychiatry, but I think also at the same time, there's a whole slew of technology out there right now who's trying to address this. And is this going to be like there will be a pocket that everybody's targeting certain population and nobody's going to be the winner? Everybody's going to be a winner because there's no one big winner. And as an investor, how do you know which one is the one that you should focus on?
Yeah, well, there's I think a cliche that is used because it's true, which is the pandemic in many ways accelerated trends that already were observable in our economy or in other aspects of our lives, and I think that applies to behavioral health. I think going all the way back to Patrick Kennedy Jr., mental health parity, right, as a starting point, as well as some economic analysis that has been done in the past by actuarial groups such as Milliman to look at the real cost of underinvesting in behavioral health, but then having higher medical costs show up in those patient populations that were otherwise being underserved by the plan design that they were presented with. And so the combination of the both started a slow migratory process, at least in my opinion, in which certainly commercial health plans were seeking to reconnect medical care and behavioral care into a more unified or at least coordinated plan design. And now comes COVID, right? And COVID creates new sensitivity, new awareness, I think less stigma, which is an incredibly positive thing for both our healthcare system and for our society. And then finally, the point that you make, a lot of really innovative technologies which do a great job of identifying patients in a variety of different ways that maybe would benefit from increased access to behavioral healthcare resources, all of which is expanded the demand side of that market, right? We've expanded the demand side because we are making more benefits available, at least for those under commercial health plans. We're increasing demand because we are destigmatizing mental health services generally. And now we have these technologies which are almost proactively reaching out and encouraging people to seek care. And yet we had access issues in 2019, 2020, right before we did any of this. And so the supply side of this market has to find a way to respond. I mean, it is the unfortunate truth that some 40% of all psychiatrists are only cash paying, will only take cash pay patients. That is a huge portion of our provider community that is simply unavailable to the sorts of patients that are at the center piece of some of the market structure innovations that we just described. I do think telehealth can play a role here because it has the opportunity to balance supply demand by region. The fact is we have better supply on the coast. We have less supply in the center of the country. Telehealth can be an effective resource to try to balance out some of that geographic disequilibrium. At the same time, right, we have to think differently about physician extenders, social workers, and nurse practitioners who can be really additive to the pool of providers that can help provide best care. And so there is a lot of investment capital that is pursuing that opportunity. It's probably got a lot of runway to go because the demand formation sides of this market are themselves just in the early innings. It's going to take a while, I suspect, for the supply side to accommodate the demand that's been created.
And I think also there's a couple things with the whole telehealth, the digitization, the access. I mean, you mentioned about a lot of the providers tend to be on the coast, but then also, as we learned during the pandemic, the access to Wi-Fi, high-speed internet is not nationwide. Yep. And also the fact that the workforce might have to change. You mentioned earlier about the social worker, how they can be also be part of the solution. How do you address that?
Listen, I think there are no easy answers, and I would add the fact that it seems probable that the DEA will finally address the congressional direction with regards to Ryan Haidt and making essentially tele-addiction, a cross-state border tele-addiction, a permitted service in a way that policy and regulatory restrictions have prevented, only adding to the dynamism of this market. So I don't think it is an easy answer, except continuing to try to organize delivery networks that have as much flexibility and as much clinical productivity architected into them, not to the disadvantage of quality of care. I think just the opposite. The lowest quality care is the patient who can't, for weeks or months, get access to appropriate mental health services. The far better quality of care and therefore outcomes is a patient who can get same day or near same day access or at least assessment and begin to be worked into a provider solution that meets them where they are for all the dynamics that you rightly described: geography, broadband access, access to a clinic setting, et cetera. And hopefully, the more we do that, the more we relieve some of the supply side challenges that, as I say, I think are going to be with us for a period of time.
And I think the beauty of this, it also attracts a lot of people who are interested in the healthcare that did not come from healthcare. And a lot of the tech people who felt like, well, I've done a lot for the tech industry. And this is a big area that the country definitely need. And oftentimes they don't understand the challenges of healthcare. And how do you, can you tell us about why companies that's outside of health space, and when they try to make the healthcare investment, it becomes challenging for them?
Yeah, no, it particularly where we live, it's a really sometimes controversial point. Obviously, there are some brilliant innovators in the technology space, many of whom either have their own personal experiences or other motivations to want to come into the healthcare field. At the same time, you've got some very well-known, well-established large corporations who have tried sometimes on more than one occasion to sort of get a foothold in the healthcare market also with limited success or mixed success over time. And so I think the question is why. And I think there are some common themes, at least that I've observed. I think, firstly, the decision-making profile in any new technology, whether it's pharmaceutical or digital health, simply isn't comparable to what you see either in a consumer environment or in a traditional corporate buying environment. You don't have the influence of physicians as a user as you do in healthcare. You don't have the regulatory dynamics, whether that's state boards of medicine, which are 50 very unique and idiosyncratic organizations, FDA or others that weigh in. I don't think you have the same underlying insistence and appropriate insistence that that safety be unquestioned relative to bringing a new technology to market. All of which frustrates and I think often limits the commercial success of those individuals. Not that there aren't examples, but just trying to bring a way of thinking from another industry to healthcare, again, has had a relatively low success rate, as opposed to partnering with individuals who are experienced in the realities, the limitations of new technology adoption in healthcare, understand, for example, what health plans require to reimburse for a new product or service, or understand, what this consensus making is going to be at an institution like UCSF, who's going to adopt a new health information technology tool set. That way you're properly setting expectations. You're capitalizing the business appropriately to take into account the long lag time that often is required, and generally, a better outcome for all stakeholders. So, listen, healthcare is obviously a large portion of the U.S. economy. It's too large, and in many ways, too far behind other industry verticals for people not to want to bring their ideas and their innovation. I think we should celebrate that. My caution to those groups would be, do your homework and make sure you sort of understand the experience of those that have come before you.
I think you start seeing a lot of the large corporation now bringing people who have the healthcare background. I think it has changed. I think maybe in the beginning they feel like the healthcare needs disruptor, and disruptor usually tend to be people from the outside, and That's probably what happened. I know I'm short on time, but one of the last things that now things are slowly opening up, and what are your thoughts about company in healthcare technology have to do to keep on growing as the world reopens?
Yeah, listen, I think one of the important adjustments I anticipate is that gaining access to providers, facilities, practices, hospitals, which was already tightening, right, leading into the pandemic, restrictions on the ability of sales reps, for example, to access physicians' practices. I think sort of the fatigue on some of the large medical society meetings, which was also kind of a key place to build awareness and adoption for innovative technologies. I think that's only going to be hardened and sustained post pandemic. And so, particularly for those upstarts, those more innovative or disruptive technologies that don't have the decades-long kind of institutional access that some of the more well-known companies do, I think adjusting for that and finding new tools and techniques to build awareness and gain adoption is going to be critically important. Digital marketing obviously is far more effective and targeted than it was in the past. But even thinking beyond that, I think is going to be one of the lessons that hopefully people learn early, as opposed to think we return to 2018, 2019 and find that the land has moved sort of underneath you.
Yeah, I hope we don't have another big pandemic, at least not my lifetime.
For sure.
Well, thank you so much for your time and your insight, and hope to see you again soon.
It was an absolute pleasure to be with you. I thank you for the invitation and look forward to following the work of you and your group further.
Thank you.
Thank you for listening to another episode of the Health Technology Podcast. We want to thank our executive producer, Herminio Neto, our content writer, Kelly Muscat, and our podcast engineer, Andrew Rojek. If you enjoyed this podcast, be sure to subscribe and leave a review. The Health Technology Podcast is available on all major platforms.